Thank you so much, sir. We'll now move on to the next academic session. This is on hematological cancers and cardio-oncology, and our chairperson is Dr. M.V. Chandrakant, who's the head of academics at Medical Oncology, NH Hospital, Kolkata. This session is supported by Dr. Reddy's. I welcome sir to the stage, and I request him to introduce our speakers. Thank you.
So, I would request Dr. Nivedita Sen, who is a senior resident at Narayana Super Specialty Hospital, to deliver a talk on bidirectional cardio-oncology.
Good morning, respected teachers and one and all present here. So today I'll be talking regarding the hematological cancers and the cardio-oncology. So whether there is a bidirectional cardio-oncology relationship. So at the outset, we know that AMI, that is acute myocardial infarction, remains a leading global cause of death. Through improved pharmacology and revascularization, there is an increased long-term survival. And with reduced early mortality, non-cardiac deaths, particularly cancer, now constitute a growing proportion of late mortality in AMI survivors. And the cancer incidence is simultaneously rising due to the aging population and lifestyle shift. Together, these trends create a dual disease burden, which is a key focus for modern cardio-oncology. So, is there any link between the acute myocardial infarction and cancer? So, we have seen that AMI and cancer both share some common risk factor, such as hypertension, diabetes mellitus, smoking, hyperlipidemia, alcohol, or obesity, some genetic changes, and low sedentary lifestyle. All these lead to some endothelial dysfunction, lipid accumulation, and chronic inflammation, which leads to atherosclerotic plaque and ischemic heart disease. At the same time, they causes releases of some inflammatory mediators which can increase the risk of malignancy as well. So there are studies which have shown that there is an increased overall cancer incidence post AMI. And regarding the timing, whether it is an acute or a late effect, that is controversial. So if it is early, whether there is related to any paraneoplastic syndrome associated, or the effect is long term. So we know that they share a bidirectional relationship. So in the healthy people, if there is iron deficiency anemia, that can lead to heart failure, which in turn can release the inflammatory cells and pro-inflammatory mediators which cause cardiac inflammation and cirrhosis, and which ultimately leads to some extramedullary hematopoiesis, or there is clonal hematopoiesis which ultimately leads to some medullary hematopoiesis. So there is a bidirectional relationship between the cardiac failure, cardiac events, along with some increased chance of hematological malignancies. So the risk factor includes, as I've already mentioned, smoking, hypertension, diabetes. Cancer therapy itself is associated with increased risk, which itself is a predisposing factor for coronary syndrome. And there is pathophysiology such as oxidative stress, inflammation. All these are they act as a predisposing factor for acute coronary syndrome. And the acute coronary syndrome in cancer patient, there is a challenge regarding the treatment decision, and there is some precautions regarding the surgical procedure as well. So what is the biological rationale for a AMI and hematological malignancy link? So they share the inflammatory pathway. So atherosclerosis and AMI, they are chronic inflammatory conditions. And persistent systemic inflammation following AMI may alter hematopoietic stem cells dynamics and create a milieu of conductive of leukemogenesis. Elevated inflammatory cytokines such as interleukin-6, TNF-alpha, CRP, and oxidative stress, they can also contribute to DNA damage, epigenetic alteration, and clonal expansion. So the clonal hematopoiesis of indeterminate potential, that is CHIP, which is a crossroads for aging, cardiovascular disease, and cancer. The CHIP involves somatic mutation in the hematopoietic stem cells that includes the TET2, DNMT3A, and ASLX1, among which TET2 is considered in particular is implicated in both AMI and hematological malignancies, providing a genetic and mechanical bridge. So there is some immune reprogramming post-MI also. So the concept is that there is some release of acute inflammatory surge. There is a massive release of cytokines like interleukin 1B, interleukin TNF alpha, that leads to mobilization of monocytes and neutrophil from bone marrow to the spleen. And there is endothelial activation and tissue infiltration. There is some myeloid bias in the hematological stem cell as well. There is bone marrow progenitor shift towards a myeloid lineage and expansion of inflammatory monocytes and macrophages. So there is a reprogramming happening in the bone marrow where there is sustained myelopoiesis and altered epigenetic landscape. So there is a bidirectional cardio-oncology link that post-MI immune remodeling increases susceptibility to cancers, and the emerging evidence are coming. And there is a thrombosis inflammation axis also. So both the AMI and certain hematological malignancies, especially the myeloproliferative neoplasm, they share a hypercoagulability and endothelial dysfunction as a common pathogenic features. And recurrent microvascular injury and compensatory hematopoietic stress coupled predisposed to clonal evolution and malignant transformation. So this is a paper which was published to see the mortality pattern and the cause of death in long-term follow-up of patients who survived the acute AMI and were treated with primary PCI. So in this picture, it was found that the cancer was one of the most important cause of non-cardiac death among the patient. So at 1 year and especially after 1 year, we can see that the incidence of cancer is much higher. So why do we need a population-based study? So given this theoretical and preliminary observation, a nationwide population-based cohort is ideal to actually elicit whether AMI independently predicts the hematological risk. The Korean National Health Insurance Services, they provided a unique data set encompassing over 50 million individuals, allowing a large-scale matching of AMI patients, a long-term follow-up, and adjustment of the numerous confounders, including the metabolic and the lifestyle factors. So this study, Wazoon et al., was published recently in 2025, that was aimed to fill this gap by systematically investigating whether AMI survivors, they face an increased risk of incidence of hematological malignancies. By isolating the hematological cancers from other malignancies, it provides one of the most comprehensive evaluations of reverse cardio-oncology that shedding a light on the shared biological roots of cardiovascular diseases and hematological diseases. So this is the consort diagram. So this study, it was a population-based study which included approximately 2 lakh participants, among which 1 lakh was, they were the survivors of acute myocardial infarction, and matched control of another 1 lakh people, with a median follow-up of 7.9 years in AMI patient and 17.8 years in the control patients. So they found that the new incidence of new hematological malignancies in the AMI group was 1.21 per thousand per persons, were compared to 0.93 per thousand persons years. So this is the graph that's showing that the AMI patient had approximately 49% higher risk of incidence of malignancies, with a hazard of 1.49, and adjusted for age, sex, comorbidities, and other lifestyle related factors. So you could see the timeline. So after post-AMI, after 90 days and up to 5 years, there is, in all the patients, there is increased risk of malignancy. And among the hematological malignancies, MPN, myeloma, and the myelodysplastic syndrome are the most common ones. So this is the forest plot showing the subgroup analysis. And in a nutshell, we can see that this study, they had proved that the AMI is one of the cause of developing malignancy in the later part. So there is a 49% higher risk of incidence of hematological malignancies, and the strongest association was with myeloproliferative neoplasm, multiple myeloma, and MDS. So what is the future implication of this? So clinical awareness and risk stratification and recognize the bidirectional cardio-oncology interplay, reinforce a modifiable lifestyle changes, multidisciplinary follow-up and targeted vigilance is required. So the post-AMI cardiac care must expand from cardiac rehabilitation to cardio-hematological surveillance, emphasizing the shared inflammatory and the clonal pathways linking the AMI and hematological malignancies. Thank you all, and thank you, ACOS, for giving me this opportunity. Thank you, sir.
So well presented, Dr. Nivedita. I think what you said is, if a patient has heart attack, the patient will develop, there is a high likelihood of developing, right? So the big criticism of this is, I mean, we know CHIP is a hematopoiesis of undetermined. So did these AMI patient have CHIP? After that, did they develop AMI? Means, was there already a hematological malignancy in the marrow that resulted in AMI, or the AMI resulted in heart attack? So this chronology is, I think that is the biggest criticism of the study.
Yes, sir.
Maybe they had CHIP already and then they developed MI and then they developed, so it's basically an evolving cancer that resulted in heart attack or heart attack in itself. So we should have had a CHIP data of these patients before they developed MI. So that is probably the criticism. And secondly, if someone has AMI, they will do more frequent blood tests. They will go to the doctor more frequently. Therefore, there is a greater chance of detection. Well. So these are the probable things which I feel in this study. Right. Good presentation. Thank you.
Thank you, sir.
Okay, next I would request Dr. Shishir Patra, who is a consultant hematologist and hemato-oncologist and bone marrow transplant physician from Narayana Hospital, Howrah. He will take us through BTK inhibitors, which he say how bad or how good they are for the heart. They are good for leukemia, but how they are good for the heart, that's what he will take to us.
So, good morning all. Thank you for giving me this opportunity. So, cardiotoxicities with the BTK inhibitors. So, on introduction, why this matters actually? Because BTK inhibitors have transformed treatment for B-cell malignancies with a better efficacy and tolerability than chemotherapy. Ibrutinib is a well-known first-generation BTK inhibitor, but nowadays there is another two inhibitors present in the market by the FDA-approved, acalabrutinib and zanubrutinib. Ibrutinib associated with cardiovascular adverse effect that is well-known, which include atrial fibrillation, heart failure, ventricular arrhythmias, hypertension. In this observational study, we aim to compare cardiovascular adverse events of all FDA-approved BTK inhibitors. So what is the importance of this clinical importance? Understanding cardiovascular risks of BTKs helps clinicians balance the treatment, efficacy and patient safety. In right side in this picture, you can appreciate there is a highest incidence of cardiovascular event in ibrutinib, followed by acalabrutinib and then zanubrutinib. So, what is the mechanism? BTK actually it's act with by the B-cell receptor signaling as part of the TEC kinase family, and it's also off-target inhibit the TEC and SRC kinases due to the structural similarities between the BTK and TEC and SRC kinases. So, cardiovascular risks usually due to the off-target inhibition that disrupt the cardiovascular pathways. In this picture, you can appreciate. So, in this picture, we can see the off-target inhibitors of the PI3 kinases that leads to PIP3, L-type calcium current, and alpha-adrenergic stimulation. That ultimately lead to myocardial dysfunction, atrial fibrillation, and ventricular tachycardia, ventricular fibrillation, and long QTc prolongation. So, what is the generational difference between these side effects? First generation BTK inhibitors have broader effect, and second generation agents show improved selectivity, but still there is some off-target activity. So, this is the common cardiovascular effect of BTK inhibitor treatment in the patient with hematological malignancy. Most common hypertension followed by atrial fibrillation, and there is a ventricular arrhythmias and heart failure. So, signs and symptoms usually elevated BP, palpitation, syncope, weight gain, edema, all these are the symptoms and signs. Diagnostic tools usually ambulatory BP, ECG, echo, cardiac MRI, score, CHAD, DS, BSC score, and the biomarkers like brain activity peptides. And what is the management? For the hypertension, as per the guideline, if systolic BP persists more than 160 or diastolic BP more than 100 millimeter of mercury, despite medical therapy, then we have to reduce the dose of the BTK inhibitor, ibrutinib, to 140 milligram OD or acalabrutinib to 100 milligram OD until the BP is better controlled. For the atrial fibrillation, if calculated score 0 to 1, we can continue ibrutinib, but if the score is more than 1, then we can anticoagulate with the DOAC and hold the BTK inhibitor. And once rate controlled, then we can use the newer BTK inhibitor or reduce the dose of the existing BTK inhibitor. For the ventricular arrhythmias, consider holding the BTK inhibitor. If appropriate, consider ischemia or heart failure evaluation, consider alternative non-BTK inhibitors like the partubrutinib, and for the heart failure, consider holding BTK inhibitor, initiate AC inhibitor, ARB, and monitor cardiac function, and consider holding BTK inhibitor and using the alternative BTK inhibitors. And types of cardiotoxicity. What are the cardiotoxicity happened with the BTK inhibitors? Like atrial fibrillation, this is most common with the BTK inhibitor, ibrutinib, affecting approximately 38% of the patient in long-term studies. Followed by hypertension, it affects approximately 70%. Ventricular arrhythmias, it's linked to myocardial fibrosis, are less common than the atrial fibrillation and hypertension, but it carries serious effect, including the sudden cardiac effect. And patient risk factor, usually this is happen with the cardiotoxicity depend on the patient age, comorbidity, and baseline cardiovascular status influencing the early or late occurrence. Now the mechanistic insight. CSK inhibitor and atrial fibrosis. Inhibition of the CSK promote the atrial fibrosis and inflammation, contributing to the atrial fibrillation. And if it inhibits the PI3 AKT pathway, then there is a leading to cardiomyocyte apoptosis, fibrosis, and arrhythmias. And ion channel like sodium and calcium channel, if they block the channels, then there is a cardiac arrhythmias. And cardiac structural remodeling, we can appreciate by the cardiac MRI, and it's lead to ventricular arrhythmia in patient with the BTK inhibitors. First generation BTK inhibitor, ibrutinib, it causes atrial fibrillation and hypertension, affecting many patients during treatment. Molecular mechanism against CSK and PI3 AKT pathway inhibition. Management strategies, careful cardiovascular monitoring needed, and dose advancement are essential to manage the ibrutinib toxicities. And clinical recommendation, NCCN guideline advise cardiovascular assessment prior to starting the ibrutinib, especially in heart condition patient. About the second generation BTK, enhance selectivity and safety of the second generation BTK inhibitor, improve the selectivity, reducing the off-target effects and cardiovascular risks like atrial fibrillation and hypertension. But still there is a some side effect is there. Like trial like Elevate RR and Aspen shows lower cardiac event rates and acalabrutinib and genobutinib compared to the ibrutinib. Guidelines and real-world data, NCCN guidelines favor acalabrutinib for higher cardiovascular risk patients, supported by the real-world data on reduced cardiotoxicity. About the real-world evidence, compared cardiovascular safety, real-world data shows acalabrutinib has lower atrial fibrillation rates than ibrutinib in B-cell malignancy. Incidence and adverse event, hypertension and cardiac death were lower with acalabrutinib, but not significantly statistically significant. And risk pre-existing condition, patients with prior cardiovascular issues have higher risk of cardiac adverse event, requiring tailored risk assessment. Real-world evidence impact studies complement clinical trials and support guidelines for safer BTKs in practice. So monitoring strategies, baseline cardiovascular evaluation is needed, ECG, echocardiography, high-risk patient before starting the BTK inhibitors, routine monitoring during treatment, quarterly ECG and regular blood pressure checks in the first year help detect the early cardiotoxic symptoms. Symptom assessment, evaluating the symptoms like palpitation, dyspnea and syncope is vital in identifying the arrhythmias and heart failure. Advanced imaging and intervention, cardiac MRI detects the structural heart changes. Early detection allows the health therapy adjustment to reduce the complications. So what is the management approach? Atrial fibrillation management use beta blocker and DOAC for the rate control and anticoagulation, avoiding the warfarin due to the bleeding risks of the ibrutinib. Hypertension treatment hypertension like RAS, and here to avoid the CYP3A4 interacting agent. Therapy adjustment, pause or discontinue BTK inhibitor therapy in ventricular arrhythmias or heart failure, considering alternatives. Individual care follow-up as per NCCN guidelines. Future direction. Enhancing cardiovascular safety. Research focuses on improving the cardiovascular safety BTK inhibitor therapies while preserving their effectiveness in cancer treatment. Non-covalent BTK inhibitors like par-2 can help us personalize risk stratification using biomarkers, imaging, and genetics to tailor the BTK therapy and enable early cardiovascular intervention. Integrating cardio-oncology, we have to involve the cardiologist to treat this patient. Now the key take-home points. BTK inhibitor dramatically improve the survival outcome in CLL and other malignancy population. BTK inhibitors are associated with more than 4-fold increase in atrial fibrillation and other arrhythmias when compared to the patient not exposed to BTK inhibitor therapy with some unique cardiotoxic mechanism. New or worsened hypertension is common with BTK inhibitors using ibrutinib, acalabrutinib, or zanubrutinib. Other cardiovascular events like heart failure, ventricular arrhythmia are increased with BTK inhibitor use. Although less than ibrutinib, newer BTK inhibitors still appear to link with increased cardiotoxic risk. Early hypertension and older age appear to disproportionately increase the risk of atrial fibrillation, other cardiotoxic event, and BTK inhibitor therapy among CLL patients. Cardiovascular events like atrial fibrillation, ventricular arrhythmia influences long-term cardiovascular and overall survival after BTK inhibitor treatment. Caution should be used when interpreting the clinical trials data for BTK inhibitor cardiotoxic risk assessment because many trials do not systematically quantify or ascertain the subclinical cardiovascular disease event. Thank you.
Well presented, Dr. Shishir. So the summary of your presentation is BTK inhibitors are cardiotoxic. Among that, ibrutinib is the most cardiotoxic.
Yes.
So the ibrutinib dose probably is 420 or higher.
Yes.
So what is your comment on a lower dose of ibrutinib? Is it as cardiotoxic as a full dose?
Yes, we can go up to low 140 milligram only.
Right.
140. And for acalabrutinib, we can go 100 milligram once daily dose.
So a lower dose ibrutinib has a less cardiotoxicity.
Less cardiotoxic, yes.
So and has a preserved efficacy.
Yes, definitely.
So the comparison between the three is with the optimum doses of each one of them. But if you lower the dose, the toxicity is also lesser.
Decreases. But if there is a atrial fibrillation is a grade 3 and grade 4, then we have to change.
Right. So between Akala and Zanu, Pitro we don't have right now.
Yes.
So between these two, which is your bet on the?
I think acalabrutinib is better because on risk stratification, whatever the data available, zanubrutinib is more side effect than the acalabrutinib.
Right. No, there are some data suggesting that atrial fibrillation is lesser when VT is high. So probably both are equivalent. So looks like both are cardio safe. Thank you, Dr. Shishir. I think we had a wonderful.
Just
Dr.
a small comment. So very recently we had a patient of follicular lymphoma who was actually started on zanubrutinib plus rituximab from outside, and what happened? The patient landed up in emergency with shock and AKI. And what had happened is that the patient had a arrhythmia which led to shock and AKI and prolonged hospital stay. So it's just that what I want to is that that sometimes these drugs can lead to prolonged hospital admission and acute complications. It's not just that they will have sometimes. So we have to be very careful when we are using these BTK inhibitors regarding this arrhythmia. It can be a fatal episode in some of these patients.
So for this, I can convey some messages like before starting, we must go ahead with the cardiological proper evaluation and take cardiac clearance before starting this medication.
I think you showed the chart very nicely.
Yes.
How to manage, how to
Yes.
yeah.
Okay.
Excellent. Thank you.
Thank you so much to our esteemed chairperson and our speakers. We'll move on to the next part of the session. I invite our chairperson, Dr. Somnath Mukhopadhyay, who's a consultant cardiologist at Manipal Hospitals, Kolkata. I request sir to please introduce our speaker and the moderator and panelists. Over to you,
Good
sir.
morning. Good morning, respected colleagues. So, without wasting time, may I request Dr. Jivan Kumar to present the speech Beyond Thrombosis, Pulmonary Hypertension and Heart Failure in patient with myeloproliferative neoplasm. Dr. Jivan Kumar is Senior Consultant and Director of BMT, Department of Clinical Hematology and Cellular Therapies, Tata Medical Center, Kolkata. Sir, over to you.
Good morning, everyone. I am thankful to organizers for giving me this opportunity and thankful for the introduction also. So my topic of presentation is in the myeloproliferative neoplasm. Myeloproliferative neoplasm can cause multiple cardiac events. So the most common is thrombosis. But in today's talk, I am going to discuss other topics, not thrombosis. Other cardiac events are pulmonary hypertension and heart failure. So the myeloproliferative neoplasm, it can be polycythemia vera, it can be ET, and it can be myelofibrosis. So majority of these patients, they present with 3 mutations, maybe JAK2 mutation, calreticulin, and MPL. The most common mutation present in polycythemia vera is JAK2, which is present in 95% patients, and JAK2 is present in around 50% patients of ET and MF also. All these patients may have high risk of thrombosis, but they also have high risk of pulmonary hypertension and have high risk of heart failure also. The risk of thrombosis is followed by risk of pulmonary hypertension, then heart failure. And myelofibrosis is the entity which have higher risk of pulmonary hypertension and also have high risk of heart failure. So the like this slide is also showing the same thing, that thrombosis is the most common complication, second is the pulmonary hypertension, and third is the heart failure. The pathophysiology behind this is the JAK-STAT pathway, which is causing hyperactivation and also cause chronic inflammation and endothelial dysfunction. So this is the epidemiology. So the incidence of pulmonary hypertension varies depending upon various studies, and it is varying from 4 to 58%. Depending on the method used in study, the definition of pulmonary hypertension used in study, like some study has used the transthoracic echocardiography, and some study has used right heart catheterization. So, but in a pooled analysis, the overall incidence is around 33% of pulmonary hypertension in MPNs. The highest risk is in myelofibrosis and the lowest risk in polycythemia vera. So, the various modalities which we can use to diagnose the pulmonary hypertension, for screening we can use transthoracic echocardiography. So different studies have different definition, and majority are saying that if right ventricular systolic pressure is more than 35, then patient has pulmonary hypertension. This is used for screening. For confirmation, we need right heart catheterization, which is a gold standard, and here if mean pulmonary artery pressure is more than 20, then patient will have right heart, patient has pulmonary hypertension. So this pulmonary hypertension in MPN, this can be pericapillary, this can be postcapillary, and this can be combined. This we can diagnose with the help of right heart catheterization. So if mean pulmonary artery pressure is more than 20 and pulmonary capillary wedge pressure is less, then majority of these patients, they have pericapillary pulmonary hypertension because of inflammation in the vasculature of lung. The post-capillary pulmonary hypertension is majority of cases because of left heart dysfunctions. So here the pulmonary capillary wedge pressure is more than 15. The combination can also occur in MPN patients. And other patients, like the patient which have extramedullary hematopoiesis, the pulmonary hypertension may be because of high flow from the heart. So these are the proposed screening algorithm. So in the screening, the patient which have any history of dyspnea, breathing difficulty, so we can do NT-proBNP, and after that it should be followed by transthoracic echocardiography. So if echocardiography is showing that it may be intermediate or high probability, then we can go with the right heart catheterization. With the help of right heart catheterization, we can divide these patients into isolated post-capillary or isolated pericapillary, depending upon the etiology. And the right heart catheterization can also assess the etiology of pulmonary hypertension. This may be chronic thrombotic cause of pulmonary hypertension. This may be because of lung disease, and this may be in post-capillary disease, may be because of left heart failure. So these are the proposed mechanisms or pericapillary pulmonary hypertension. So various agents are shown that these can cause pulmonary hypertension, but it is not confirmed. But various studies have shown that like chronic thrombotic embolism is also a risk factor. Other is that the bone marrow is producing endothelial progenitor cells which can go into circulation, and they can cause proliferation and neovasculature of the endothelium, which is also a risk factor for pulmonary hypertension. Other is the activation of JAK-STAT pathway. And also in the lungs, we have megacardiocytes and platelet, which is producing like lysosyl oxidase, which can upregulate the vascular fibrosis and adhesions, which can be the cause of pulmonary hypertension. Other less known cause are, it may be because of some non-driver mutation, because of TET2, DNMT, or because of extramedullary hematopoiesis. These are the various pathophysiology of pericapillary pulmonary hypertension. So all the causes like thrombosis, or because of extramedullary hematopoiesis, or because of the bone marrow produce effect endothelial cells, JAK-STAT activation. So all these can cause pulmonary hypertension in the lungs. So there are other mechanisms for post-capillary pulmonary hypertension, which may be due to left heart disease. The left heart disease can also be increased in patients with MPN. And JAK-STAT pathway, it can be linked with cardiac fibrosis and heart failure phenotypes. The non-driver mutation like TET2, DNMT3, they also cause myocardial fibrosis and remodeling. This pulmonary hypertension, this is a bad prognostic factor for MPN patients. Like right ventricular dysfunction, this is a strong predictor of right heart failure and cardiovascular mortality. And also the patient which present with pulmonary hypertension, there is high risk of hematological progression. It is around 2 times that these patients may progress to myelofibrosis, or they may develop into secondary acute leukemia. Now the heart failure is also increased in patients with MPN. So the incidence is around 1.5 to 2 times as compared to general population. Again, the myelofibrosis is the most affected of MPN, and polycythemia vera is less affected. And because of extramedullary hematopoiesis, it may be because of high output heart failure. The mechanism of heart failure, it is similar like JAK-STAT pathway. It causes myocardial remodeling and fibrosis, which can cause to left ventricular failure. Other mutations like TET2, DNMT3, they also cause heart failure progression because of cardiac remodeling. So the implication of heart failure is also similar like pulmonary hypertension. The risk of death is increased in these patients, and majority of patients with myelofibrosis, they have more risk of developing heart failure and mortality. So for the diagnosis, initially we have to take the history of the patient, then echocardiography, pro-BNP, we can check to look for the heart failure. And from the disease perspective, we can look for extramedullary hematopoiesis. The patient with extramedullary hematopoiesis, they have high risk of heart failure. The management of pulmonary hypertension and heart failure, there is no specific management in myelofibrosis. It is similar to the guidelines of heart failure and pulmonary hypertension. So, but depending upon the etiology, if there is thrombosis, we can treat according to thrombosis. If there is post-capillary, then you have to manage the left heart. And in the pericapillary, we can give the drugs like endothelin receptor antagonist and PD5 antagonist. And in the heart failure, it is similar to heart failure in the patient without MPN. So this may be beta blocker, diuretic, AC inhibitors. So we have to, in future, we have to do some prospective trials of patients of MPN who are developing pulmonary hypertension or heart failure, because the incidence data is very variable, ranging from 4 to 60%. And for all these things, we need a collaboration between cardiologist and oncologist. Thank you.
Thank you, Dr. Jivan Kumar. So regarding heart failure, it is specially high output heart failure in one side. Another side is perhaps heart failure with preserved ejection fraction, mainly due to the fibrosis and the other things. So thank you for your excellent presentation. May I request to join with me? Another thing is microvascular dysfunction, that is also important in this regard. So our next speaker is Dr. Suman Mallik. Sir, you can join with me because the panel discussion is here. Or you can just... Dr. Suman Mallik. The talk is radiotherapy for mediastinal lymphoma, a thing of the past, late cardiotoxicity, and after anthra and radiotherapy. He is Clinical Director, Chief of Radiation Oncology, Narayana Hospital, Howrah. Sir, over to you.
Thank you, Chairperson, sir, and dear colleagues. So it's a very important discussion about whether to give radiotherapy in mediastinum because it's a kind of double-edged sword. So we know radiotherapy can cause cardiac morbidity, and also we know in some situation radiation also improves survival. So it's a basically a balance between benefit and risk. So role of radiotherapy is evolving in last 2 decades and it's still evolving. So we were in pre-PET-CT era and now we are in PET-CT era. So now the indications of radiotherapy are evolving. So if you look at the radiotherapy techniques as well, so previously we used to give a non-conformal radiotherapy where there was significant dose to surrounding organ. So from non-conformal technique now we have moved to conformal technique. But if you look at the radiation dose distribution in the conformal technique, low dose spillage is more in this kind of conformal radiotherapy. So there is a risk of spillage of low dose radiation to other important organs. So this was the left hand side, this was the typical radiation field when we were a student. So mantle field radiotherapy used to give for the lymphomas or mediastinal lymphomas. Then we moved to more restricted field which was known as involved field radiation, and involved field shown the similar outcome compared to larger fields. Now then we moved to involved site, and now we are actually discussing about whether we can avoid radiotherapy in many situations. So why radiotherapy is dealt differently from other indications, especially in lymphoma, because most of the lymphomas, they do require anthracyclines as a systemic therapy. So when you add anthracycline with radiotherapy, there is a significant chance of cardiac morbidity which is around 50% after 40 years, because we see long-term survival in this kind of patients. So there are 2 risks. One is cardiac risk, and second is there is a risk of second malignancies. So if you look at the risk of second malignancies, it increases with the dose except for thyroid malignancy, because if you go beyond 20 gray, we see reduction of the secondary thyroid malignancies due to radiotherapy. That is more associated with low dose radiation. And if you look at the cardiac toxicity, so it's a variable, and no dose of radiotherapy is safe for cardiac morbidity. So as low as reasonably achievable, that is our target. So for cardiac toxicity, we need to reduce our dose as much as possible. So when we talk about mediastinal lymphoma, usually we come across these types of lymphoma. One is primary mediastinal B-cell lymphoma, diffuse large B-cell lymphoma, Hodgkin's disease, and marginal zone lymphoma. So in Hodgkin's disease, if you look at the trials, in pre-PET-CT era, all trials have showed there is improvement in overall survival when you use radiotherapy after chemotherapy. But in post-PET-CT era, if you can actually determine the complete response, because we know PET has a very good negative predictive value. So when you actually decide a complete response, if you avoid radiotherapy, and if you compare with radiotherapy, especially with the Byakov regime, we have seen there is no difference. So these group of patients, actually we can avoid radiotherapy even in advanced Hodgkin's disease. If you look at diffuse large cell B-cell lymphoma, there the evidences are kind of sketchy. So still it is recommended for bulky disease and where there is a partial response. And primary mediastinal B-cell lymphoma, it's a distinct group of patients where we usually see mediastinal mass in younger females, and they have other markers to diagnose a primary B-cell lymphoma. And if you look at the outcome of primary B-cell lymphoma with or without radiotherapy, after complete response, there is no difference. So now radiotherapy is not recommended in primary B-cell mediastinal lymphoma after complete response. So this is only indicated when there is partial response, or if there is a relapse setting, whether it's a first relapse or second relapse, or sometimes it may be used as a bridge therapy while doing a CAR T-cell therapy. So these are the indications for the primary B-cell lymphoma. So this is a meta-analysis published few months back in large B-cell lymphoma of mediastinum, and it has shown that radiotherapy improves progression-free survival, but there in certain cases, especially in mediastinum, there was no significant benefit in overall survival. So in some cases, we can avoid radiotherapy in diffuse large B-cell lymphoma. Radiotherapy now having an emerging role by combining with the CAR T-cell therapy, especially at the time of bridging therapy, early salvage, and at the time of salvage itself. And this is the typical radiotherapy bridge for the RT in CAR T-cell therapy. Now the thing is, whenever we consider for giving mediastinal radiotherapy, it is important to provide a conformal kind of radiotherapy, and we have to avoid heart as much as possible. For avoiding heart, we have several options. So apart from conformal techniques, we also use DIBH or inspiratory breath hold technique, where actually we increase the distance of heart from the radiation field, by which we can reduce the dose to the heart. We restrict the dose to the heart as low as possible. So we always try to keep it less than 1 gray if possible. And it is also important to reduce the dose. So from 45 gray historical dose, we have reduced to 20 to 36 gray. 20 gray is usually we recommend for Hodgkin's disease, 36 gray for non-Hodgkin lymphoma. For low-grade non-Hodgkin lymphoma, we have reduced it further to 23.4 gray. And there are certain other techniques like proton or particle beam therapy, where we can significantly reduce the heart dose. So these are the techniques we have to reduce heart dose or reduce morbidity or reduce chance of late toxicity due to radiotherapy in mediastinum. So modern RT is all about lesser dose to your organ at risk with lesser morbidity or long-term lesser morbidity. So to summarize, so we have de-escalation strategies in place. We have refined indication. So now usually we follow the metabolic response based approaches, like to see after seeing the PET CT, and whenever possible always use modern radiotherapy techniques to reduce dose to the VAS. So thank you very much.
Thank you. Please be seated and join after this wonderful talk. One thing I have to add, that after radiotherapy, you make our job very difficult, that in coronaries, especially the osteoproximal diseases are so important and so difficult to treat, that it is first thing, it can happen in less than 40 years of age, and during angioplasty also, these are difficult to tackle diseases, these osteoproximal diseases post radiotherapy. So without wasting, our next speaker is Dr. Rajiv Bhattacharya for how to treat DLBCL CV consideration. He is Senior Consultant Medical Oncologist, Peerless Hospital, Kolkata. Over to you.
Yeah, thanks a lot. Today I will discuss the various cardiotoxic things associated with DLBCL treatment. Let's begin with the case report. This is a 75-year-old gentleman. He had comorbidities like hypertension, diabetes, and NYHA functional class 3 heart failure. So he presented with palpable axillary and inguinal lymphadenopathy, fevers, chills, night sweats, shortness of breath, and weight loss for 20 pounds in the last month. Biopsy showed DLBCL. They did a PET scan and it shows disease both above and below the diaphragm, which signifies a stage 4 disease. So these are the systemic treatment options for high-grade B-cell NHLs. We now use R-CHOP. We have polatuzumab vedotin now in the first line as well. There are other, in double-hit lymphoma, we use dose-adjusted EPOCH as well. So these are the systemic treatment options. But the problem with these options is that anthracycline is a part and parcel of these first-line regimens. And there are a lot of cardiotoxicity issues associated with doxorubicin, especially when the dose goes above 250 milligram per meter square. And a cumulative lifetime dose of doxorubicin is recommended to be kept definitely below 400 milligram per meter square. Apart from this, increasing age, prior heart disease, various comorbidities like diabetes, hypertension, these are all risk factors for anthracycline-induced cardiotoxicity. You can see that these are the various frontline DLBCL treatment regimens in cardiac frail patients where they have tried to remove anthracycline and they have tried to replace it with etoposide, gemcitabine, etc. And they have also used to give up, in the last line you can see that they have used RCVP, which has completely given up anthracycline and not replaced it with anything else. And that has produced very poor results. So it's only a palliative therapy in very frail patients. And this is one trial by Mosia et al. And where they had shown that you can replace anthracycline with etoposide. That's what we do in our practice as well. And still you can get some benefit, albeit slightly lesser, but they are not statistically different, but definitely lesser in terms of numericals in anthracycline-free etoposide regimens. Now, how can we mitigate these cardiovascular risks? We can dose reduce the regimens, like we can use R-mini-CHOP. We use it regularly in our practice. Liposomal doxorubicin can be used. Infusional anthracycline, so slow IV infusion can be tried. And concomitant administration of dexrazoxone is another approach. So these are how we treat in newly diagnosed DLBCL. First, either if there is no baseline significant cardiovascular disease, we go ahead with R-CHOP. If yes, then we can use R-CHOP or RGCVP. And when they are relapsed, then we also have option of stem cell transplant, immunotherapies, or CAR T-cell. So in the patient, he was treated with R-CHOP for 6 cycles, and he achieved complete remission. The PET CT scan, the first screening PET CT scan, unfortunately revealed lymphadenopathy in the mediastinum, axillary, and inguinal areas. So the response was short-lived, actually. Lymph node biopsy showed relapsed DLBCL. So what are the options that we now have? We can have autologous stem cell transplantation, especially if the disease has relapsed more than 12 months. In this patient, it has come back earlier than 12 months. We can use in this situation CAR T-cell therapy for this patient as well when they have relapsed so soon. And there are various other novel immunotherapies that are present, loncastuximab, tesirin, polatuzumab vedotin. These are antibody-drug conjugates, and there is tafasitamab, etc. And we can use combination chemotherapy regimen like RIs, RDAP, etc. So in cardiotoxicities and cardiovascular optimization of auto stem cell transplant and CAR T, both the auto stem cell transplant as well as CAR T are associated with potential cardiotoxicities. High dose chemotherapy administered with SCT is associated with significant risk of developing CVD such as heart failure and accelerated coronary artery disease. And the risk increases in stem cell transplant survivors, that is actually twice that of in general population. So this is a paper by Armenian et al. Which which devised a CVD risk score for those treated with stem cell transplant. These risk score include age, anthracycline dose, chest radiation, hypertension, diabetes, and smoking. So those patients who were in the high risk group, you can see that they were at 7.8 times higher risk of developing CVD compared to those who considered low risk. You can see that in the graph. What are the cardiovascular events that can be seen in CAR T cell therapy? Yes, we can have hypotension, pulmonary edema, heart failure, arrhythmia, cardiac arrest. All these things can happen. And mostly these are caused by the systemic cytokine release syndrome. There are a lot of cytokines which leads to myocarditis, and that finally leads to these sorts of cardiac events. So these are the various cardiovascular toxicities that you can see. They can be from the various newer agents like selinexor, ibrutinib, bispecifics, tafasitamab. All of them have cardiac toxicities. So you can't save them. We need to have good efficacious drug that will produce cardiotoxicity, and that's why herein comes the balance. Radiotherapy, I think Shubhan sir has already explained that cardiotoxicity is indeed a side effect of mediastinal RT. Short-term effects include pericarditis and pericardial effusions, and long-term side effects will include coronary artery disease, arrhythmias, cardiomyopathy, valvular dysfunction, and heart failure. And there are certain risk factors like higher dose of radiation, whether cardiotoxic chemotherapy has been used along with it or not, or presence of pre-existing CVD. So the patient was treated with medical therapy to optimize cardiac function. He underwent CAR T cell therapy with lisocabtagene maraleucel. He achieved complete remission 1 month post CAR T, and he developed axillary lymphadenopathy with biopsy-proven relapse 3 months later. It's a very bad disease actually. So he is currently on single-agent loncastuximab tesirine. So my take-home messages would be that we have to develop improved treatments for the DLBCL patients with cardiac conditions, both in the frontline and relapse setting, and that is a significant unmet need. A multidisciplinary approach between cardiologist and oncologist is paramount in addressing reversible cardiac risk factors for DLBCL patients, medical optimization and monitoring cardiotoxicities of these treatments. And upfront cardiology involvement, I think this is very important, that we need to involve our cardiology department along with our management from the very beginning in management of the cardiac risk factors and CVD in conjunction with us to maximize successful outcomes and minimize DLBCL treatment toxicity is critically important. Thank you.
Thank you. Thank you for incorporating us in your management regime. So what I can see, just a minute, what I can see that if the ejection, we have to look for prior echocardiography for the DLBCL management. What I can see, if the ejection fraction, that means if the LV function is little bit less, say around 45 to 50%, around 45 to 55%, then perhaps the job is largely ours to smooth your path, to smoothen your path for treatment. But if the ejection fraction is less than 45%, I say around 30%, less than 30%, then perhaps you have to choose the other treatment regime for that management. So prior initiation with ACE inhibitor, beta blocker, and the other cardiological drugs, and especially statin, for the management, initial initiation of those management followed by DLBCL treatment is of utmost importance if the patient is suffering from LV dysfunction.
Definitely, definitely. I think the importance of cardiologists in this situation is really very much high.
Another question I think you are asking.
So Dr. Rajiv, two situations is there. Suppose you get a patient of around 65 years who already has a ischemic heart disease and the ejection fraction is 35% and patient is DLBCL. So what regimen will you use to treat this patient? And second is a patient, just as Dr. Somnath mentioned, as to somebody who has a ejection fraction of around 50% and patient is diabetic, hypertensive, not a known ischemic heart disease, but under follow-up of a cardiologist with a borderline ejection fraction of 50%, asymptomatic. In that patient, what will you choose as your frontline regime?
In our medical oncology training, the one thing we learn is that beware of anthracyclines. So they are very dangerous and they produce irreversible cardiac effects. So that's why when you have such a low ejection fraction, in that point of time, I would not risk the patient's life with anthracycline. So that's why maybe, although CVP has shown very bad result, I think CHOP can be tried. We can try it at COP. We have tried it in some of our patients, along with the cardiological assistance in that situation as well. And when you have an elevated ejection fraction, we can try anthracycline in those situations, giving, first of all, with statins and ACE inhibitors, beta blockers with the help of our cardiologic friend.
Correct. So I'll just ask, madam, what is the practice in TMH, when you get such a borderline, patient with already a low ejection fraction, but still a borderline ejection fraction. So, would you like advise your hematology department that please go on and start anthracyclines, and we'll start, the cardioprotective treatment for these patients, especially when the ejection fraction is 50%, 48%, 51%, and you know that it is not optimal, but it is not so optimal. Patient is asymptomatic.
I mean, any patient with the ejection fraction of less than 50%, the risk increases. So generally, we suggest to avoid anthracyclines. And other thing is, which everybody should explore, is the use of dextrazoxane in these patients with high risk.
So I think, if logistic is not a concern, then I would be very, very happy to, use dextrazoxane in that 50% category patient, and start anthracycline without any concern. But I totally agree that it does become a very, sort of iffy kind of a situation. And if there is anthracyclines are something that gives you the best, response. It is probably equal to what rituximab is for, lymphoma, in a high-grade lymphoma. And in an aggressive disease, without anthracyclines, you feel that you may not be able to achieve. So it does become a iffy decision, and dextrazoxane does, help.
Yeah, because it is a common practice in the
West, yes,
that they use. The high-risk patients, they will go ahead and give as much anthracycline with dextrazoxane.
Yeah, but you can import dextrazoxane.
It's available. I think Dr. Lingaraj has the contact.
Yes, so you can import dextrazoxane and you can use it. We have used in 2 of our patients. But
that is guideline recommended also, perhaps, recent guideline.
See, really the ejection fraction is not the big game changer actually. Cancer is the problem. You treat cancer with one of the best drugs you have. It's the first line drug. Leave the heart to the cardiologist. We have been treating people even with the ejection fraction 25%. We treat them and we do a low dose dobutamine test to see the contractile reserve and tell the oncologist to give the best possible treatment. We are not going to change anything. See, even if the EF is 25%, if it is 55%, 65%, there is a risk of drug-induced toxicity. There is a risk. It's not that because the EF is low, if you give anthracycline, there will be more dysfunction. It's not like that. There is a risk. So, if somebody has got cancer, our responsibility is to treat cancer. And then LV dysfunction has to be treated with the maximum tolerated medical treatment.
Sir, I have just one question to the house and the cardiologist, is that how low is the too low of ejection fraction for giving anthracycline?
For us, there is nothing like that.
Nothing like
we treat
that.
everybody, irrespective of
LV
dysfunction. We treat the LV dysfunction, we monitor and tell the oncologist, give the best treatment. Why there is second line? If the second line drug was safer, why not that as the first line? You give the best treatment. When somebody comes with cancer, you cannot treat his heart. You cannot say your brain, kidney. No. Someone comes with hypertension, treat hypertension, not diabetes.
So aggressive management of heart and aggressive management of cancer, both
are important.
Both are important and to be done simultaneously.
Any other drug would be okay, but with anthracyclines, I mean, okay, max I can push it to 45. Below that, no risk.
We give we have treated people even cardiogenic shock.
My experience is different.
We have treated them and put them on.
And what risk
tell the oncologist, give the best drug. Rest we will see.
But as such,
nice discussions. So next speaker is Dr. Shaurya Ghosh for MES after CART, and he is consultant clinical hematology and cellular therapies, Tata Medical Center. Over to you.
Good morning, everybody. Thank you for the invitation here. So the topic given to me was incidence of major adverse cardiovascular events in patients treated with CAR T-cell therapy. The study was conducted in University of Pennsylvania. So, and this was a prospective study. So the background is that CAR T-cell therapy has now emerged as a revolutionary treatment for hematologic malignancies. And the basis of this study was that there were retrospective data to suggest that the MACE, or the major adverse cardiovascular toxicities, were higher with CRS. So this was the basis of proposing this prospective study, and they wanted to study this systematically. So the design was, initially it was based on sample size calculations. 50 patients were to be enrolled, but due to various logistic challenges and the time period coinciding with the COVID pandemic and a negative study, they they closed the study preliminarily, and 44 patients were only included. These were patients with CD19 positive malignancies, so basically B-cell malignancies. The median follow-up was just over 1 year. This is the interquartile range. The assessments were serial echocardiograms, biomarkers, and clinical evaluations at baseline, then at 2 days, 1 week, 1 month, 6 months, and during the duration of CRS. The primary endpoint was the incidence of MACE, acute, and the MACE was defined as any cardiovascular death, symptomatic heart failure, acute coronary syndromes, or stroke or new arrhythmias. So just to give you the background, CAR T-cell therapy is a game changer in relapsed refractory B-cell malignancies, and across the drug trials, it has achieved around 65% progression-free survival at 1 year for patients who are really poor risk patients. And it basically involves taking the patient's own T cells and genetically modifying them to change the target of the T cell and trigger it towards the patient's own B tumor cells. And then these are infused back into the patient, and that gives the anti-tumor immunity and cell kill. So the cardiovascular concerns are that, so basically when we infuse such cells, there is a robust systemic inflammatory response that is called as cytokine release syndrome. This can become life-threatening, and this is also, during this phase you can see a lot of cardiovascular events. This was seen in the retrospective cohort, and that is why they wanted to study it prospectively. So, and that is linked to the cytokine release, endothelial leakage, hypertension, myocardial injury, and then subsequently multi-organ dysfunction. So patient enrollment was adult patients with CD19 positive malignancies receiving the commercial product at UPenn between July 2019 and February 2022. They collected all the baseline data. And as I mentioned, MACE definition and adjudication was done independently by 2 cardiologists, and CRS was graded as per the ASTCT guidelines, that is from grade 1 to 4, based on fever, hypertension, oxygen requirement, need for vasopressors, etc. So these were the patient characteristics. There were total 44 patients with a mean age of 58 plus minus 11 years, 70 predominantly male. At baseline, 43% of the population had hypertension, 43% had dyslipidemia, and 30% had diabetes. These were the comorbidities. Majority were lymphoma, only 1 patient had ALL. These were the prior cardiotoxic treatments. So these were the cardiotoxic comorbidities that they had received, So 84% had received anthracyclines, 32% underwent chest radiation, and 25% had a stem cell transplant prior to the CAR T-cell treatment. So baseline cardiac function, the ejection fraction was 62, which was normal. The GLS was normal, and also the biomarkers were normal. The cohort demonstrated higher cardiovascular risk burden, as you can see, than age-matched controls. So key findings, cytokine release syndrome happened in 52%, almost half of the patients. And this was the commercial product. Now, we have been using CAR in India. The cytokine CRS rates are much lower. And out of the 52%, 13 were grade, so majority were mild to moderate. So 23 patients had grade 1 or grade 2 CRS, which is basically fever and with hypotension. The grade 3 hypotension responsive to fluids. Grade 3 and grade 4 were limited in this cohort. Median time to CRS was 4 days, which is the normal what we see. And 7 patients received tocilizumab, which is an IL-6 blockade agent that is basically the driver behind the CRS. The major cardiovascular, the MACEs were only 2 patients. So this is basically why they stopped the study prematurely, because they did not find the requisite number of events that they had hoped for. So only 4% had events, out of which one was heart failure with preserved ejection fraction 6 days post-infusion. The other was de novo AF. Both patients experienced grade 1 to grade 2 CRS and were elderly with multiple risk factors. Median time was 3.5 days. So just over a year of follow-up, mortality was 27%. This is all-cause mortality, and median time to death was 378 days. No cardiac deaths occurred. So during the CRS, these 2 patients demonstrated elevated heart rate, increased CRP, increased ferritin, and increased NT-proBNP. So the cardiac functions, as per echocardiography, there were no changes in the LVEF. The GLS there was a temporary and modest decrease at 1 week and 1 month post-infusion, as you can see, from minus 21% to 19%, and they were reversible. Right ventricular function there was not a major difference in or drop in the right ventricular function or in the diastolic parameters. So the clinical significance was that there was a modest decrease in GLS, and that was reversible, and there was no significant changes in left ventricular ejection fraction. So basically they found a lower MACE than expected. The grade of CRS was low, and there was aggressive early intervention. So this is why they kind of speculate in the paper that the patient selection, these were early onset, the earlier line patients who were treated, so the cardiotoxicities and the comorbidities were less. Then there was better treatment, more early interventions, and vigilant monitoring. These led to a lower incidence of cardiovascular events as compared to the retrospective cohort. So these were the conclusions, that you have to monitor better, and you should have heightened vigilance, and early tocilizumab administration may help prevent organ damage. And these were future directions that were mentioned in the paper, that you need more prospective studies to confirm the low MACE events. Thank you.
Thank you.
Yeah, Dr. Chorio, nice presentation. Just asking you a simple question, that in your practice, do you look for subclinical cardiotoxicities in your patients, and how do you do that?
So
what is your experience?
Yes, so prior to any transplantation procedure or a CAR T cell procedure, we do an organ function assessment for all patients, which includes a cardiac evaluation. Now, most
do
of
a GLS?
We don't have the facility to do a GLS, but it is more objective and better nuanced in picking up early changes rather than a drop in EF. So yes, it is definitely required, but we don't have the access to it as of now. Apart from that, we do the basic, cardiac workup, which includes an ECG, echo, and in certain situations, as prescribed by the cardiologist, a Holter. But that is pretty much it. Where we face problems are with the post-transplant cyclophosphamide group. So that is, in the allogenic transplantation, when we use PTCY, we have had a lot of cardiac events. We've had a lot of, significant drops in cardiac function, and we need to have risk mitigation strategies. We have no personal experience of using iron chelators like dexrazoxane, and I would like to know the cost of the product, if at all it is required in certain patients and who can afford it. if it's, the cost of the product. If you have any.
This
Yeah, the thing is,
Sorry?
The cyclophosphamide is probably the only thing which is really scary.
Yes, it's very scary.
But then you have to really coordinate, and you can do the GLS, and I can offer you, we can keep online training for your people.
Right.
To do the GLS. It's not any rocket science.
So what I've realized, what I've understood is, if I've understood it correctly, you need a special software within the echo machine.
That's there in the echo machine.
It's there in all machines.
Yeah.
No,
Oh.
no, sir, it's not there in all machines.
All new machines have it.
Because, sir, I had to fight with my hospital to get that installed. Since 2 years at both our Howrah hospital as well as the R.N. Tagore hospital, now we are doing GLS for most of our patients, and I had to, sort of fight with the administration to get that software installed.
What is the cost of the software?
It doesn't cost anything.
Okay.
Yeah,
There are certain
it's
machines
not very high.
Lower end machines may not have.
Right.
Most of this, all standard machines comes bundled with this.
Right.
If you buy a very low end machine, it may not have. But off late, even the lower end machines have it.
Right. And the principle is quite simple.
It's
So
very, very simple.
exactly.
My sonologist takes 30 seconds
Right.
to do GLS.
Okay. Thanks a lot. Thank you.
Thank you for your presentation. Please join with us. So our next speaker is Dr. Rajiv De, who is clinical lead BMT program, Narayana Super Specialty Hospital. He will speak regarding CV toxicities post-HSCT, early cardiotoxicity of post-transplant cyclophosphamide study, postural hypotension and tachycardia after this, and review CV disease after hematopoietic stem cell transplantation. So what do you?
Yeah, good morning, everybody. First of all, I express my regards to the organizing committee of this Cardio-Oncology Summit, because it takes a really courage to organize such a conference, because we have so many conferences, so many oncology conferences, but specifically the Cardio-Oncology conference, it is a rare of its kind, and it is being organized for last 2 years. So Dr. Vivek Agarwal and Dr. Chandrakant, needs from my side, I sincerely thank you for organizing this conference and inviting me. This cardiovascular toxicities after hematopoietic stem cell transplants, there are 3 articles was given, but I just made the preparation as an overview of cardiovascular toxicity with references from the articles. So overview of hematopoietic stem cell transplants, that we know that HSCT is basically intravenous infusion of hematopoietic stem cells to re-establish the hematopoietic function in patients with hematological disorders or immune disorders. And we know that over the years, be it United States by CIBMTR data or the Europe by EBMT data, the number of transplants are increasing year by year. And the basic 2 types of transplant is autologous, where the own stem cell is utilized, and allogeneic transplants, where we have the healthy donor, be it a matched sibling donor or matched unrelated donor or haploidentical donor because of the small family size and unavailability of the matched donor in the family. Cord transplants, we are not doing essentially the cord transplants nowadays because of a lot of issues. And these are indications. For autologous transplant, the most common indication is multiple myeloma, which usually occur in the older age group, having a lot of cardiological toxicities, cardiological comorbidities. And for allogenic transplants, mostly the refractory leukemias, as well as some inherited disorders like thalassemia, anaplastic anemia, these things. Now, the crux of the transplant lies in the conditioning, how we manipulate, how we do conditioning. And it is actually associated with a lot of complications, mainly the cardiovascular complications. We have a wide range of conditioning, starting from the myeloablative conditioning, where the comorbidities, the complications are much more, compared to now the REAC and non-myeloablative conditioning. And then there are post-transplant complications because of GVHD prophylaxis, GVHD management, vasculopathies, so on and so forth. And post-transplant, we arbitrarily divide between the early post-transplant period up to 100 days and then late post-transplant period beyond 100 days. And these division is completely arbitrary. There is no scientific reason between that. So we divide acute and chronic GVHD depending on the 100 days. So that's why it is transcribed to all the post-transplant complications. If we see India, the number of transplant, the first transplants were done in TMH in 1983. But over the last 1 decade, there is exponential rise in the transplants. Now we are doing almost 4,000 transplants per year. We are doing more haplo transplants nowadays. We are doing more transplants in the older age group. So because of that, we need to manage more HSCT complications nowadays. And a lot of complications are there, mostly GVHD, infections, but cardiovascular toxicity is one of them. And if we see that there are at least 2 to 6 times more cardiovascular complications in the post-transplant period, and the major cardiovascular events occur in 4 to 10% within the 5 years, and it is as high as 20% by 15 years. And we know that anthracyclines, as we were discussing, anthracyclines and TBI, total body irradiation, is very important cause for the cardiovascular toxicity post-transplants. The amount of anthracyclines patient received pre-transplants. And so now there is an integrated cardio-oncology care is the standard of care, because we can't go away with anthracyclines in most of the cases. So we have to accept that those risks are there, then how to deal with it. So these are the different short-term and long-term cardiovascular complications post-transplants. That is atrial fibrillation is the most common, around 2 to 10% short-term, and around 5 to 11% in the long-term complications. Then ventricular tachycardia is less. Heart failure ranging from 0.4 to 10%. Then vascular diseases like ischemic heart disease, stroke, myocardial infarctions. So these are although less, but the overall risk factors, the cumulative effect of the cardiovascular complications long term, it is not less. It is as high as 20 to 30%. Mechanism, we know that this conditioning regimen, inflammation during engraftment, GVHD, management of GVHD, all this causes vasculopathy. And this vasculopathy is mainly responsible for pulmonary hypertension, systemic hypertension, heart failure, cardiomyopathy, and all sorts of things. I am not going to details of this. So this is the common pathology of cardiovascular complications and post-transplant complications. First, we need to do an initial risk stratification for that, as we do for all the cases. And for that, we have now a standard risk scoring that is called KR-BMT scoring, which includes demography, age, 50 to 54. Then, according to that, they score 1 to 3. There can be a cancer related, whether the transplant type, allogenic or non-allogenic. Anthracyclines, more than equal to 250 milligram per meter square used or not. Then history of coronary arterial disease, heart failure, peripheral arterial disease, then creatinine more than 1. So these are the scoring, and the total scoring is up to 16. If it is 0 to 1, it is a lower risk, causing 1 year cardiovascular event 1.7%, 5 year up to 4%. But if it is a high risk, that is more than 5 point, then the 1 year cardiovascular risk is 11.3%, and 5 year is as high as 22.4%. We know that we transplanted use an HCTCI. It is more commonly used. All transplant patients, we use HCTCI. If we go through it, it is not cardio specific, but if we go through it, we can see that most of the criteria are basically cardiac related. So whether there is arrhythmia, cardiac dysfunction, then diabetes, which is a cardiovascular risk factor, moderate pulmonary disorders. So all these criteria, if it is fulfilled, then lower risk is have a 2-year non-relapse mortality of 14%. Higher risk has a 2-year non-relapse mortality as high as 41%. So there, it was extrapolated to the KR-BMT scoring, and it modified. And so these two scores we use to see the cardiovascular toxicities of a transplant. And I can skip this. We need to do evaluation, pre-transplant evaluation that we do in all patients. Usually we do MUGA, but echocardiography, in most of the cases it is sufficient, but in high risk cases we need to do Muga scoring or if possible the transthoracic echocardiography. And there are patient-related factor, transplant-related factor, cancer-related factors. I just, because of the shortage of time, I'm skipping these things. ACT-related factors, what the conditioning regimen we are using. One toxic agent is cyclophosphamide. So previously we used to use a high dose cyclophosphamide during the period of BUSI and FLUSI. So now we use the the cyclophosphamide mostly, we give a lower dose of cyclophosphamide, and in haplotransplants we are using PTCY. Even the PTCY, the dose we are using 50 milligram per kg, it is much less than what we were using previously, 120 to 140 milligram per kg. So cyclophosphamide related cardiotoxicity is much less nowadays. Only in PTCY cases we found this. Then this is a GVHD management. GVHD management we mostly use with steroid. So that causes high risk of diabetes, hypertension, and these comorbidities for cardiovascular events. So these are there. I skip this slide. Biomarkers are used, but there is no strong data to support the role of biomarkers in predicting the cardiac events, be it is NT-proBNP and those things. Preventive strategy should be used properly, that is aggressive BP control, aggressive dyslipidemia control, this should be in place. Cardioprotective drug, these have role in preventing the cardiac toxicities. Multidisciplinary cardio-oncology approach team should be there, which we have in our center. And as sir mentioned that give your heart to your cardiologist. So we follow in our team because we don't manage the cardiac part. It is a cardiology team who manage. So in short, that is the proposed recommendation for cardiovascular complications in HSCT. These are the short-term and long-term complications. And this is a baseline assessment: medical history, physical examination, BMI, blood pressure control, lipid profile, HbA1c, 12-lead ECG, TT if possible, or Muga, and then functional assessment. And then this is the risk stratification depending on the transplant-related mortality, ACTCI, or KRBMT score. And then we need to adjust the conditioning regimen according to it, and we need to treat cardiotoxicity if it is there with the following agents. And monitoring is very, very important. Post-transplant, initially 3 monthly monitoring, and then after 1 year, we need to do a 6 monthly monitoring. So here, I just give you the message. There is a group called Eastern India Blood, Marrow and Cellular Therapy Group. There are 12 centers across the 10 cities of the eastern and northeastern region. We have 22 centers. We have started accumulating our data. We have till now transplanted in this region under EIBMCT more than 2,000 transplants. Every year, these are all the centers which are part of it. And last year, we have performed nearly 400 transplants. So as it is a very niche area, so from EIBMCT, we can collect the data on the cardiotoxicity of HSCT. I can request Dr. Chandrakant and Dr. Vivek to take the initiative because as you are focused on it, so we can collect our own data from the eastern and northeastern region to what is the cardiovascular toxicity in HSCT in our region. Thank you.
Thank you, Dr. Rajiv De, for your excellent presentation. So I have a point that can you explain anything or can you throw some light regarding the calcineurin inhibitor and concomitant use of atrial fibrillation drugs? Especially, we have to look for that verapamil and diltiazem. These two drugs are actually very notorious if the simultaneous use of calcineurin inhibitor is there.
Yeah, so again, as sir mentioned, we can't go away with calcineurin inhibitor in transplant. We have to give. We have, in some desperate conditions, replaced with mycophenolate mofetil, but the outcome is not that good. Especially in the today's era of haplotransplants, we have to give. So we usually try to give as, and there is an, we do the blood level. The blood level, if we use TAC, the range is 5 to 15. In those cases, we used to use a lower blood level, that is 5 to 6, rather than the higher dose. But in the initial phase, we, as in haplotransplants, we are scared of graft rejection. So our tendency is to keep a higher blood level. But in particular cardiovascular disease cases, and when these agents are being used, we used to use a lower blood level. And as far as cyclosporin level is concerned, again, we use around 150, just borderline, to maintain the lower blood level, and definitely take the help of our cardiological colleague to help us.
How
Thank you.
frequently you find hypotension in your patients post
Hypotension?
Hypotension in when postural hypertension in patients post transplant.
Very difficult situation. We can share our own experience. Few months back, we performed a systemic amyloidosis transplants with a cardiac amyloidosis. The ejection fraction was 42, the maximum ejection fraction. But it was a desperate situation. With the help of our cardiological colleague, what we did is we gave a prophylactic NORAD throughout the transplant course for 3 weeks, along with the diuretics. In that way, our cardiological colleague helped us, and we could discharge the patient. So we have one, Dr. Vivek is also in our team, Dr. Shishir is there. So we together could manage patients of cardiac amyloidosis with 42% ejection fraction in that way.
Actually, the postural hypertension is very common in patients post-transplant, and it is sometimes a challenge. Sometimes you get a call saying the patient fell down, fell from the bed, like. So it is.
We do very strict monitoring.
We can do what we can do is in some patients we do give midodrine.
So what he is asking is that when we have our patients following up, do we always check for postural hypertension? Do we check the
That is
in a lying down, in a sitting position, in a standing position to see whether they are having postural hypertension or not? And this is something that, at least I would say that, we are not actively doing in our practice to check for postural hypertension. And this is something that we should, do, because that is what sir is saying, that it has a high incidence of postural hypertension in these patients.
We are not doing it regularly because we have a dedicated post-BMT follow-up clinic. To tell you the truth, we are not doing regularly for all the patients, but definitely patients with pre-transplant cardiotoxicity, that we do. And
But the factors must be well contained. That's what we can do. There, as you said, there's no cardiac drug we can do, ACE inhibitors, ARB, anything. Nothing really protects. But especially incidence of postural hypertension is very high.
Yeah.
And you have to train your people who are taking the vitals to check the BP supine, sitting, and also in standing.
That is a very important input. So I will keep it in our post BMT follow-up clinic. So that will be thank you for
thank you. Thank you everybody for this wonderful session. May I request Dr. M.V. Chandrakant, Head Academics, Medical Oncology, Narayana Hospital, Kolkata, for a panel discussion to moderate the panel discussion. And may I request Dr. Rakesh Gopal, Dr. Shishir Patro, Dr. Deepak Padmanabhan to attend this.
Right, so I think it is just a revision of what we heard in last 20 minutes, and let us take the opinion from our experts. Right, so we had 7 papers that were serially presented in a serious way. Let's take our input from the panelists, right? So we have cardiologists. So we don't have Dr. Deepak, but I would request Dr. Somnath to replace whenever his name pops up. Right. So this is the first paper, bidirectional cardio-oncology. Those who have blood cancers have higher AMI, and those who have heart attack have higher blood cancer. So this is bidirection. Right. So non-cardiac deaths after heart attack are recognized and emerging data says those who got heart attack have a higher 50% chance that someone will develop blood cancer. So Dr. Shaurya Ghosh, you can take this up in your practice. How do you look at this? Patients who have, how often do you see cancer in patients with a history of myocardial infarction?
So thank you for the question. So this is a very interesting paper actually, and this is a very interesting observation that some of the risk factors of cardiac disease and hematolymphoid malignancies overlap. So in our practice, we are not regularly seeing, we don't have prospective data, or we don't have our own data correlating these two, but there is what should I say, there are in US right now there are actually CHIP clinics. So what is CHIP? CHIP is basically clonal hematopoiesis of indeterminate potential. Basically there are some clonal mutations that are happening in the in a inflammatory milieu. So the marrow microenvironment has a lot of inflammation. There is a lot of clonal hematopoiesis that is happening there. So these clones can actually be picked up using next-gen sequencing from the peripheral blood. Now they have found out that these mutations are linked to a lot of other diseases which seemingly we would not associate with myeloid mutations, like cardiovascular diseases, atherosclerotic disease, and some other immune diseases as well. So how do we treat them?
Right.
There is no guideline as to how, if you get a CHIP mutation, what you do with it, apart from good surveillance and maybe lifestyle modifications.
Right.
And we need to do that here as well, because we are seeing a lot of lifestyle disorders as well as malignancies.
Right. So very important information. CHIP is the culprit.
Yeah, Dr. Chandrakant.
Yes, sir.
My point is, see, here how many patients with cardiac events develop hematological malignancies. So the cohort is not available to us. The cohort is available to cardiologists, because we can see how many patients with hematological malignancy can develop cardiac events. So I think our cardiological department should focus on it to get the actual data.
Yeah, so in this paper, the major drawback is that there's a surveillance bias. So if you have a cardiac event, you are more likely to go to a doctor go to a doctor. So the chance of getting diagnosed with a myeloid neoplasm or a hematological neoplasm inherently increases because you are under surveillance more often.
Right. So now that we understood that heart attack surveillance we are doing more frequently. So Dr. Rakesh, what is your thought? So if a patient with heart attack, do you keep seeing CBC? क्या हो रहा है CBC में?
No, not really. Long term we don't because we are, see, the thing is, the risk factors for development of cancer and risk factor for development of cardiovascular disease are exactly same. It correlates more with breast cancer, correlates more with prostatic cancer, especially with the hormonal therapy. But in general, especially tobacco, it can cause both. And CHIP is the real interface, both can happen. So now these patients being followed up, it's not that we should scan for cancer, we should scan for cardiovascular disease. It's about seeing all these patients as patients, and then now we say MI patients more like, even the same with even with the CRF. Even patients with renal failure are more prone to get cancer.
Right.
Patients with cancer are more prone to get renal failure. So there is like, people, unless they were dying from infectious disease, they started dying of cardiovascular disease, cancer, degenerative disease. This is a spectrum which is going on.
At least after this paper, as a cardiologist, if there is an abnormal WBC and RBC, probably you will have a lower threshold to send to a hematologist or an oncologist.
We should actually, like we typically test urea, creatinine, HbA1c and lipid profile. CBC may also be should be a part of it.
Right. Dr. Shishir, how do you look at these? If there is a history of heart attack, I am more vigilant in blood.
Yes. So my point is that nowadays all kind of cancers, hematological or medical oncological cancers, all are increasing. Incidents are increasing. So, if there is a patient who come with after the EMI or any cardiological events, if there is a WBC count like, yes, it is like 4,000 to 10,000 is normal, it is 3,500, it's okay. No, I think we have to go with the simple one test, peripheral smear examination. And if the pathologist is good, he can able to understand that there is some dysplastic neutrophil, some dysplastic RBCs, and some NRBCs is there. So that is the catch point, and from that we can go back to see after the chips or all these things.
Post MI follow-up, not just cholesterol, ECG, echo, CBC with peripheral smear is the key.
Completely echo with Dr. Patro, because whatever we call ourselves, super specialty or subspecialty, we have a tunnel view. So we see only our part. So from the hematology or hemato-oncology part, we can give this message. Along with whatever you are doing, at least do a CBC. And not only the hemoglobin or TCDC, please do CBC peripheral in the visit, then you can pick a lot of things.
Chandrakant, I've got a question. Is it related to radiation? Because pre-thrombolytic era and now there's a booming of PCI and CT angios. Do you find any study related to radiation and
radiation, if at all, cause long-term
hematologic malignancies in cardiac patients?
Radiation, if at all, in long term can cause chronic stable
So this radiation was there in both the cohorts. The cohorts who had MI, the cohorts who didn't have. So they followed up. That was confirmed. That was
what is the commonest hematologic malignancy in this cohort? AML, CML.
So
this is the
surprisingly, in this cohort of some 100,000 patients, they found myeloid malignancies to be more common. And yes, they did not do a competing risk analysis to remove the confounders. Despite that, they found the hazard ratio in this to be more.
So I'm raising this question because MI leads to a lot of modulation of TNF alpha. A lot of work is going on. Anti-inflammatory drugs in MI.
That's the reason.
So there must be some correlation how the like AML causes a lot of AF, we know. And the MAR is occurring because of TNF alpha.
Sir, about your point of inflammatory markers, sir, we have actually I have seen both of us on I think 3 to 4%, and recently one CMPN patient who come with the cardiac events. So there is actually, if there is inflammation, but which way? Either due to the diabetes or due to hypertension or metabolic syndrome, or due to the hematological chief. So both are going hand to hand. Okay.
So I think also the thrombotic state which the MI creates leads to more of a myeloid dysplasia. But it's also very interesting that when the world was developing, CML was more common, and with the developed countries, if you see, the CLL is more common. So I think, from the pro-inflammatory state in a stress-induced environment to the well-developed amenities and facilities, and now we have lymphoid, something related here also that can be there.
Right. Right, sir. Dr. Jeevan, your comments, quick comments. We are stuck with first paper itself.
Yeah.
So,
it may be possible that these patients have hidden a chip before diagnosing AMI, and that chip has caused some inflammation and some damage in the endothelium, which has provoked the AMI. It may be possible. And these myeloid malignancy like myeloproliferative neoplasm may have indolent cause. The patient may have a high hemoglobin, may have slightly more platelet, may have polycythemia or ET, which were not diagnosed at the time of AMI. Later on, it was diagnosed. That may be the reason.
That is a chronology he is stating. There was a chip, then MI, then you found a hematological malignancy. That's the sequence. Anyway, so let's. So, Dr. Rajiv Bhattacharya, your thoughts on this? Why it happens? These are some mechanistic insights.
Yeah, so we already have discussed why chip produces this cardiac toxicity. But the problem with doing a routine screening for chip is that, first of all, it's very expensive. You need a deep NGS to look at that. Sometimes if you, even if you do find out chip by screening, what will you going to do with it? So you have to give the general cardioprotective drugs. You do not have any targeted drug against chip. So I think I don't believe that there are any recommendations for routine screening of CHIP. So I think it's still.
If there is something we can do for CHIP, then all heart attack patients will come to hematologists or
See,
oncologists.
it's going to be a big problem if you are going to screen CHIP for everybody. And the fact still remains that most patients who have CHIP, nothing happens.
Right.
So the take-home message is don't chase CHIP, but do CBC in all AMI patients.
Right. That's very practical. I think that's the thing. So blood cancer increases heart attack increases hematological malignancies, shared pathways, CBC at least is the way to go. Right. Okay. So first paper we have taken 10 minutes, a lot of time. Let's see the BTK inhibitors in CLL. So BTK inhibitors we have so many, ibrutinib, Bacala, Zanu, Pitro, so many are there, and they share something like off target, on target, so all the side effects. So Dr. Somnath, you want to take this up? Should BTK inhibitors now be considered cardiotoxic agents like anthracyclines?
I think because of mainly risk of atrial fibrillation is very very high.
So they're as cardiotoxic as anthracyclines. That's
See, the ibrutinib especially has one of the highest incidence of AF, and it can cause thrombosis, but more it can cause bleeding. So it is something strange that is different from the other drugs.
Right.
And the last two drugs actually do not cause much of a problem.
Right.
But that's maybe because we are not using them. If you start using them, only we will know. But ibrutinib, be very careful if somebody says palpitation, and at the same time if there's some evidence of bleeding, and if we are using if they are on 10 antagonists for whatever reason, we should be really telling the patient that the risk of bleeding.
so you can take up this question. So what do you do, sir? Like if someone you want to do a halter, and how do you monitor?
We did a study in our department that is ibrutinib is associated with significant platelet dysfunction, and that significant decrease in the platelet aggregation those who are on ibrutinib. So bleeding risk is a very important, as I mentioned.
Right. So if we refer a patient to you, let's say ibrutinib, patient had arrhythmia, okay. So how do you look into that patient? How do you handle that patient?
We'll treat the cancer.
So we're treating cancer with ibrutinib.
Yes.
So now there is a
Side effects we will manage.
right.
If ibrutinib is the best for the patient, as a cardiologist, I have no business to tell the oncologist don't treat.
Right. Okay. So I think this week took care. So yeah. Let me be quick.
If I may ask, what is the absolute contraindication for a BTK inhibitor?
There is no absolute contraindication.
From the cardiac point of view?
There are only indications.
Okay.
There is no absolute contraindication.
So how
Cardiologist's role is to support maintained treatment of cancer.
So
he is not there to say stop.
Right. So for various other reasons, we are not using ibrutinib right now for not for medical reasons, but we are using acalabrutinib, which is now easily available. Now anyway the risk is less. The cardiac risk is less with
because
acalabrutinib.
we are not sure about it.
I mean,
we have not been using acalabrutinib like we are using ibrutinib.
There is Western data to
but still,
suggest,
the problem is, if you give a drug which is less effective in curing cancer and buying a side effect, okay, that is not acceptable.
So
you give the best and then take a hit. That is different than giving a second line drug and still getting hit.
Right. If somebody does have, let's say, chronic AF and we are prescribing a BTK inhibitor, how frequently or what would your how would your monitoring change? How frequently would you like to see the patient?
See, most of the conventional ablation and all will not work in these patients because it can be multiple foci and we do not know what is the real reason. So you have to be carefully anticoagulating them and control and rate control. It's better, I don't give antiarrhythmic drugs to most of the patients with cancer because there are there are not just driver mutation which leads to certain things we know. There are multiple things, many things happening. Some of them are driver mutations. Some of them are still affecting in a different way that may have an impact on cardiovascular system. So we do not know. So don't give antiarrhythmics, but we can rate control and anticoagulation is still the cornerstone.
Right. Dr. Rajiv, do you change a BTK? Have you changed based on cardiotoxicity?
Yeah, it is already mentioned. As Dr. Shauri also mentioned, we are not using ibrutinib. Number one, it is not available frequently. And number two is the side effects. Side effects both, the cardiotoxicity as well as
between the Acala and the Zanu, both of them are available right now.
Yeah, so
there are some
acalabrutinib is more preferred because of the cost issues,
Right.
and when Xanu will be available, just we'll
Xanu is
look
there,
into
sir,
it.
available.
Yeah, zanubrutinib.
Right.
But acalabrutinib is fairly tolerable, fairly safe, and we need to see how effective it is. But this is in CLL. When we use acalabrutinib, it is a lifelong treatment. So immediately outcome assessment is very difficult. So okay, we can say that the drug is safe compared to the ibrutinib.
Right. So we are done with the CLL. So 13 more minutes. So this is, we thought it's only thromboembolism with myeloproliferative neoplasm, and there is pulmonary hypertension and heart failure. So Dr. Shaurya, you want to take this up? So MPN, do you ever think of pulmonary hypertension, heart failure in these patients?
Yes, I mean, we don't actively screen, but what we do, as we have discussed earlier, that what we do is do a baseline echo for the patients. But for non-thrombotic cardiac disease like pulmonary artery hypertension, or we are not actively screening. But yes, when they become symptomatic, as we have discussed in the previous sessions, it is very important to screen for these
We
things.
seriously screen all patients with cancer for PH. Not just drugs like dasatinib, because they've got 70% risk of developing pulmonary hypertension, and they have worse outcomes if you don't treat.
What extra test do you, sir, other than echo?
We do a careful right heart study with echo, and that is standard for everybody. And PH, we say, oh, this patient's RVSP is 40, 45. He has cancer, why should you bother? No, we aggressively treat. Now there are at least 6 drugs which can treat pulmonary hypertension. 20, 25 years ago, there was 0. Someone developing severe PH was a death sentence within 6 months. Now, we are keeping patients alive with PH with multiple drugs, not just selexipag, riociguat, not starting with, though we started sildenafil. We have multiple patients on at least 6.
Are they equally effective even in the background of a hematological malignancy?
Just one query I wanted to ask is, we have good drugs for primary pulmonary hypertension, but when there is a pulmonary hypertension secondary to MPN, so is it like a primary pulmonary hypertension, or it's a secondary pulmonary hypertension?
See, basically it is more common in patients who have a marrow which is fibrosed, and then pleuritic cells, which is also found in the, about Heath Edwards' classification of the pulmonary hypertension, that plexiform angiopathy is more common in those patients who have myelofibrosis, and those patients who are, if the platelets alone is increased, and in this polycythemia vera, these patients have more of venous thrombosis. Okay, then they can have pulmonary embolism, and they can also have PAH, both. They are effective. In my space, we have been aggressively treating PAH in every patient with cancer, and they are equally effective.
I think
and one drug which you can try is, if nothing works, add vitamin C. You can give 1000 milligram twice daily for 4 weeks in resistant pulmonary hypertension despite multiple drugs. Many of them respond very well.
Dr. Jeevan, we give Jakavi or these molecules for preventing them to progress or for symptomatic benefit. So now there is another endpoint, it will take care of pulmonary hypertension also. So do you keep this also in your mind?
Yeah, so pulmonary is a patient of MPN. With the passage of time, like if after 5 years, majority of these patients may present with pulmonary hypertension, and when patient has pulmonary hypertension, there may be disease progression also. There may be extramedullary hematopoiesis, there may be secondary myelofibrosis in patient with PV or ET, or there may be transformation to leukemia. So the risk of transformation is almost double in the patient with pulmonary hypertension.
Right. So funnily, it is more common in can you just go back to the previous slide? Just one. See, it's a combined PAH, post and pre. That is the most common. So it's like it's a fluid thing. We really.
So you should treat both.
Yeah.
Like give cardiac medication
Yes.
and also treat the cancer.
Yeah.
Because pulmonary hypertension is lethal. Right. Right. So I think so if someone is developing pulmonary hypertension, that means probably the disease is also progressing. This is some indirect hint, right? Right. Okay, so we are done, and then now comes one more paper, anthracycline radiation. Even so, how safe are they? Is there a lower limit of this? So, Dr. Malik, you can take this up. In modern lymphoma care, do we underestimate cardiotoxicity due to low dose radiation techniques?
So basically, as I mentioned, so now we have de-escalated our treatment in the sense of dose. Second is in the sense of field and as well as indication. So we are avoiding radiotherapy in many cases of lymphoma where we used to treat before, even 10 years back. Second, if you look at the radiotherapy techniques, it has evolved, and now we give much lesser dose to the heart, because and it's always as low as possible, and it's possible with the newer radiotherapy machines. And you know that now proton beam therapy is available here, so usually it is recommended to send your child and adolescents for proton beam therapy if logistically that is important. And the third thing is reduction of the dose. So previously we used to give high. Now we see even with the lower dose we can achieve same outcome with the lower dose. So we can use lesser dose. So that is also important. And now we understand, previously we used to measure only the mean heart dose. Now we understand the dose to each part of the heart, which include even pulmonary vein, all the chambers of the heart, coronary arteries, these are important. And we have some information, preliminary information about the threshold of the dose to these organs. So we always try to maintain that dose.
So we have lowered the dose, better techniques, proton if feasible. These are some messages in childhood actually.
See, when you talk about proton, we are the only center currently in India using proton. But when I do not know how you people manage to have a maximum benefit of not including the heart if you have to treat the cancer. It's not easy. It's not easy. Another thing is, worldwide, there are only in the US, I think there are only 4 or 5 centers which are proton. One of them is Case Western Reserve, where I was trained. It's like an old building and nobody actually goes there. So if you think proton will cure everything, no. But proton can definitely give a much lesser dose. But whether it is going to clinically meaningful differences in the outcome is yet to be seen. We have seen people, no, you don't include heart, but still you do a GLS immediately after the proton therapy, where the heart was not in the field, but still GLS is abnormal. So
we need long-term studies on proton. That's probably
we need
right. So Dr. Rajiv Bhattacharya, you can take this up. So should we have lower anthracycline limits? Not shoot up.
So radiotherapy does cause a lot of toxicities, cardiotoxicity, and it also sensitizes the myocardium to the harmful effects of anthracycline. So I think already ASCO, ESC, they have advised that you should limit the dose of anthracycline to less than 250-300. And more importantly, that those patients who have received radiotherapy at a younger age and who have to be given anthracycline at an older age for some other reason, they are even more sensitized to anthracycline. In that case, I guess the cumulative dose is even less than 200. So that thing I think we have to take into consideration.
Right. So there is no safe anthracycline, there is no safe radiation. But having said, whatever minimum dose required, not the maximum tolerated, but the minimum dose required.
There are only correct doses.
Right. Okay, so 5 more minutes and DLBCL, RCHOP is the standard of care, doxorubicin, and there is risk of cardiotoxicity. So this is what we just heard. The dose is more than 400 is where the risk is higher, and these are the risk factors. Age, radiation, and gender. All these matter. And let's come straight to the questions. So these are the alternative regimens that we use. I think we just discussed post session. So there are some questions to just address. Dexrazoxane. So any experience of dexrazoxane with hematologists? In sarcoma we do use. Right. So curative intent versus cardiac risk. Dr. Rajiv Dey, you want to answer this? How do you balance the curative intent and cardiac risk in older patients?
As sir mentioned, that is, we need to take care of the primary malignancy, DLBCL, as well as we need to do the pre-chemotherapy cardiac assessment, proper cardiac assessment, take necessary steps to give the maximum cardio protection, and take help from the cardiology friends to optimize. So our main target should be not to reduce the chemotherapy as much as possible, and in a desperate situations we can reduce. And in older people it has been seen that overall outcome with CHOP, RCHOP and RCVP is not statistically significantly different in older population. So we can opt for that. And what happens after few doses, 2-3 cycles of CVP, sometimes the cardiac function improves. Then we can add on. So it is not that. So there lies the experience and proper assessment of the cardiological function. It is not that if there is a cardiac dysfunction, we have to give the full dose. So there is an option we can omit for two cycles, right, reassess, and then add the anthracycline.
Right, so dexazoxane we are not using. Dr. Jeevan, how do you take up 45% ejection fraction?
Yeah, here we can use other drugs like etoposide. You can give gemcitabine or polatuzumab.
Non-anthracycline based regimens.
No, I disagree with you on this. If ejection fraction 45%, even if 25%, still treat the cardiac condition and give the best possible chemotherapy. These patients can develop LV dysfunction after 5 years, 10 years, and they may have a serious issue, but that is because the patient is alive. You treated cancer, patient is alive. So if it is children, you give mantle radiation. Or
but it is irreversible. You give anthra, it's irreversible. The heart is going to go.
Yeah, those cells are dead. Okay, those cells are dead and gone. So even if identical twins in childhood, if one has received radiation and anthracycline, many of the myocytes die, but they don't manifest. By the age of 40, 50% of these patients will be in heart failure,
right,
because their heart will be smaller for the body surface area. Okay, so what do? Don't give? No. He has heart failure at 40 years of age is because he is alive out of cancer. So if you didn't treat cancer, you won't see this patient. No one will scream from the grave.
Right.
Sir, okay. Just one comment. I think sir is the dream cardiologist for any oncologist.
We will have teleconsultation with you. Right. Dr. Somnath, you want to...
I'm not entering into that debate. I will start beta blocker and AC inhibitor as preventive tool. Right. And nowadays ARNI is also coming.
Right. Okay. So this is maze and CAR-T. I think CAR-T is a different ball game and has its own side effects. The CRS is an issue that you see. And let's take up some questions on CRS. So, So CAR-T, Dr. Rakesh, you have any experience of CAR-T and any references you have got in your clinic?
All patients who are going for CAR-T needs a baseline risk factor assessment and ECG, echocardiography. But we do not do cardiac MRI or anything in these patients. We don't do sometimes we do a stress test and it ends there. No imaging, because it can unnecessarily confuse and it has got nothing to do with the prognosis.
Right. So what do you look in the echo? Yeah. So the VLS biomarkers.
No standard biomarkers for them because it is essentially supposed to be normal. But echo will include strain rate imaging.
Right.
And so you have a baseline thing, and you should always be able to say what you see in GLS is real. Right. It's not an artifact. So some areas the automated algorithms can miss. Right. So what you do is go manual mode and then see the areas where you see abnormal GLS, that area separately you can see whether what is actually happening, whether it is red in color, if it is color coded. And then you can mention that as that particular areas. Right. And if you think it is still abnormal, then you should record infraposterolateral strain rate is low. It is not artifact. That has to be mentioned. So that when the patient becomes sick later on, when you do, it is difficult to do at that time. When you do that, then you know, oh, this area was abnormal before, or this is a new development.
Right.
Just, those of us who are doing transplants, specifically the difficult complicated transplants, haplotransplants, we have a complacency that CAR-T is very easy things. And before transplant, we do a stringent monitoring and take clearance from the cardiologist. That kind of protocol is not there for CAR-T cell therapy. I think the way we do pre-BMT screening, in that way for CAR-T also we should do the screening and take clearance from the all relevant departments.
Right.
Chandrakant, I think in the interest of time, maybe we can continue the discussion and,
right.
and we
So
can
I think
let the
wonderful
session go
panel.
on.
Yeah, I think wonderful session. I think we have a lot of things to discuss, never ending, but fantastic thoughts. I think heart he will take care, cancer we will take care. That's what is the message. Thank you.
It's about the right drug for the right patient in the right dose.
Right. Yeah.
So there's nothing like
so that is what
dose, nothing
so
like alternative therapies.
Permissive cardiotoxicity is the key.
No, we are treating cancer.
Right.
I won't take that word, the permissive. Okay, that
you don't permit cardiothoxicity.
We are trained to be treating people and curing people. We don't permit somebody to have a
but
problem.
we need to take care of the heart too.
But yes, patient is alive. I told you, somebody dead won't complain.
Right. Thank you, sir. Thanks all the panelists for your active participation. Thank you.
Thank you, sir.